Dear colleagues, in this video I will be illustrating the technique of unilateral biportal endoscopy for addressing lumbar canal stenosis. I am Dr. Ashutosh Kumar from the Department of Neurosurgery, SGBJ, Lucknow. Lumbar canal stenosis is a growing public health burden. With aging population worldwide, nearly 1 in 3 individuals above 60 years shows radiological stenosis, and it remains the most common indication for spine surgery in elderly. The demand for durable decompression with minimum morbidity has never been greater. Unilateral biportal endoscopy represents a paradigm shift in how we approach this disease. It combines the familiarity of open anatomical landmarks with the magnification and illumination of endoscopy, allowing true bilateral decompression through a unilateral approach. However, the safety and reproducibility of UBE hinges on one structure, the ligamentum flavum. A detailed understanding of its layer architecture, midline cleft, and facetal attachments is important for a successful decompression. This is a 56-year-old gentleman with progressively worsening neurogenic modification over 2 years. He was unable to stand beyond 2 to 3 minutes due to bilateral buttock and lower limb pain, more pronounced on the right side. Conservative management had failed. Neurologically, he had no focal motor deficits. MRI demonstrated significant ligamentum flavum hypertrophy at L45, resulting in central canal stenosis, bilateral lateral disease compromise, and foraminal narrowing. Bilateral facetal arthropathy was also present. Dynamic radiographs showed no significant instability. This case represents a classic example of central and bilateral lateral disease stenosis without dynamic instability. Therefore, decompression without fusion was planned. The patient was position prone under general anesthesia. The hips were flexed slightly to open the interlaminar window. The patient was operated on from the right side. Under fluoroscopic guidance (AP view), the working port was marked cranially at the level of L4 pedicle, just medial to the medial pedicle line. A vertical 8 to 10 millimeter incision was made and extended caudally. The wing port is created 2 to 3 centimeter caudal to the working port. This configuration allows an ergonomic instrument maneuverability while maintaining a stable visual axis. Docking too medially necessitates excessive drilling of the spinous process base to access the contralateral side. Docking too laterally creates an oblique working trajectory and compromises the fluid outflow. Vertical incisions are preferred as they allow easier conversion to tubular or open techniques, especially during early phase of learning curve. Horizontal incisions, however, may be more cosmetic. Lateral fluoroscopy is mandatory after docking to confirm the correct level. A fountain sign confirms appropriate portal placement and adequate fluid dynamics. Here the docking has been done on the right L4 hemilamina. At its inferior edge, the interlaminar window is identified. The root of the spinous process medially and the laminar facet junction laterally should be identified before beginning the laminectomy. The laminectomy is done with the help of a 4 millimeter burr. The drilling is performed in a sweeping fashion like a feather brush in a cranicaudal direction, avoiding any direct pressure towards the thecal sac. This technique avoids inadvertent injury to the dural sac due to the plunging of blood into the spinal canal. We can identify the sulcus between the lamina and the onset of the facet and the isthmus. Drilling is done till this sulcus, which is a good landmark for the lateral extent of the laminectomy. The drilling is done such that initially the upper cortical layer is removed, then the cancellous layer is removed, and finally the inner layer. The inner cortical layer is drilled paper thin. This exposes the underlying ligamentum flavum, which appears as a yellow structure. The ligamentum flavum is removed en bloc by employing the Z sequence technique. It entails detachment of ligamentum flavum all around, along its margins. While detaching the ligamentum flavum from the under surface of the lamina, there can be epidural bleeding. It is controlled with a radiofrequency coagulation. For contralateral access, the root of the spinous process is drilled. This takes us to the contralateral lamina. We can see here the inner cortical layer and the cortex of the contralateral lamina. It is further drilled inside out over the intact ligamentum flavum. The median cleft of the ligamentum flavum is identified here. It is an important landmark for surgical orientation. The inside out drilling of the contralateral lamina over the intact ligamentum flavum prevents dural injury from the burr as well as the radiofrequency ablator used for hemostasis. Here, the contralateral inferior facet is reached. The medial half of it is removed, exposing the facet joint. Using radiofrequency ablator, the attachment of the ligamentum flavum to the superior facet is removed. The contralateral facet complex can now be well visualized here. We then return to the ipsilateral lamina facet junction of the inferior vertebra. The superficial layer of ligamentum flavum is detached from the upper margin of lower lamina. The plane between the superficial and deep layer is carefully developed. The superficial layer is removed first, which significantly increases the working space and maintains anatomical orientation. The deep layer is then detached. Now, the ligamentum flavum can be removed en bloc. The sequential fluectomy helps maintain orientation and reduces the risk of inadvertent dural tear, particularly during early learning phase of UBE. Limiting the use of Carrison punches further reduces the risk of dural injury. The ipsilateral traversing nerve root is completely free now. The contralateral superior facet, medial half, and the tip are removed with Carrison and drill to decompress the contralateral lateral recess and the traversing nerve root foramina. The decompression has been done till bilateral pedicles. Here, the contralateral lateral recess and the contralateral foramina are now adequately decompressed. The thecal sac is pulsatile, and bilateral nerve roots are freely mobile and supple. This marks the completion of decompression. Closure is done with drain, which is removed within 24 hours. The patient was mobilized on the same day. He reported complete resolution of the cortication symptoms. He was discharged on post-operative day 1. Post-operative CT confirmed adequate bony decompression with preservation of facet integrity as per our previous surgical plan. This case demonstrates that bilateral decompression can be safely achieved through a unilateral biportal approach while preserving facet integrity and maintaining spinal stability. A detailed knowledge of surgical anatomy of the ligamentum flavum is essential for precise decompression in these cases with UBE. Thank you.